Hello, everybody. My name is Mandeep Virk, and I will be talking about elbow stiffness today. As we all know, the function of the elbow joint is to position the hand in space. It's a complex synovial hinge joint consisting of three articulations: the ulnohumeral, radiocapitellar, and proximal radio-ulnar joint. The functional range of motion of elbow is described as a flexion-extension arc of 100 degrees, typically described as between 30 and 130, and a supination-pronation arc of 100 degrees, typically described as 50 degrees of supination and 50 degrees of pronation. Elbow is prone to stiffness, especially in flexion and pronation after trauma and inflammation. And there are multiple reasons for that. After trauma, there is a preferential capsular response, which involves selective thickening and contracture of the anterior capsule and the collateral ligaments. Elbow has a complex articular anatomy, so intra-articular mechanical aberrations or malalignments are poorly tolerated, especially at extremes of range of motion. There is an imbalance of muscular forces, with the flexors being stronger than extensors, and elbow is prone to HO and myostatic contracture, all of which contribute to increased predisposition to stiffness. The etiology of elbow stiffness can be extrinsic or extra-articular, and intrinsic or intra-articular or combined. Myofibroblasts are the important cells involved in capsular stiffness. The three most common causes of elbow stiffness includes post-traumatic, primary elbow arthritis, and inflammatory elbow arthritis. So when examining a patient with elbow stiffness, one should make a distinction between the pain which is present at extremes of range of motion and pain which is present during the arc of motion. The pain at the extremes of range of motion is usually mechanical in origin, coming from osteophytes and loose bodies, and pain present throughout the arc of motion is usually secondary to synovitis and is usually seen with inflammatory pathology. Patients with locking episodes usually have loose bodies, even though you may not see them on plain radiographs. If there's limitation of flexion extension arc only, then the pathology is most likely limited to ulnohumeral and radiocapitellar joints. And if the pathology also involves the supination-pronation arc, then it most likely includes the radio-ulnar component as well. It's important to distinguish the endpoint to resistance of motion. A soft tissue contracture typically will result in a softer endpoint, and a bony block which results from osteophytes is usually hard and abrupt. One should look for symptoms of ulnar neuritis and signs of compression neuropathy, and you should also look for prior scars from surgery during examination of a stiff elbow. Plain radiographs are the initial imaging modality. I typically get 3 views of the elbow, but you can order additional views depending upon the pathology. It is important to know that loose bodies that are chondral in nature will not be clearly visible on plain radiographs. CT or MR imaging is the advanced imaging, which is good to have for preoperative surgical planning. It is a sensitive tool for accurate assessment of joint congruency, joint space narrowing, presence of gutter osteophytes, and location of loose bodies. This is a typical slide of my preoperative plan. As you can see, I have an AP and a lateral view. And then I have 3D recon images of the front, back, and side of the elbow. Then I have additional 2D images that points towards obliteration of the coronoid fossa, obliteration of the olecranon fossa, presence of loose bodies, and presence of gutter osteophytes. So with this basic imaging and advanced imaging, it gives you a good idea of what your steps should be in terms of addressing elbow contracture release. Coming to treatment, the initial treatment is non-surgical. A typical trial would be 3 to 6 months. Non-surgical treatments are particularly effective within first 6 months of injury or surgery. In acute phase, compression sleeves, ice, and anti-inflammatory medications are particularly helpful for reducing swelling. You can use oral or intra-articular injections, especially in inflammatory arthropathy. Splinting, two kind of splinting techniques are employed. The static splinting, which is more popular and well tolerated by patients, involves a passive progressive stretch 2 to 3 times a day. It relies on the principle of stress relaxation, and you guys can be tested on this. And dynamic splinting, which is less well tolerated by patients because you have to be in this splint for a long period of time during the day, and it relies on the principle of creep. Manipulation under anesthesia works well when done within first 3 to 6 months of injury or surgery or stiffness. The average reported gain is around 25 to 30 degrees in flexion extension arc, and it is less effective for improvements in supination pronation arc. Flexion is more easy to achieve compared to extension. If you are doing MUA in setting of trauma, you have to wait for the fracture to heal, and one should be aware that manipulation under anesthesia in situations with bony ankylosis can result in fractures. So surgical treatment is predominantly in form of elbow contracture release, either done open or arthroscopic. The other treatment options of interposition arthroplasty and total elbow arthroplasty are more of treatments for frank arthritis of the elbow, and I think Dr. Kwan is going to cover them in his talk. So indications for elbow contracture release is a flexion extension arc less than 30 to 120 degrees, and if a patient relies on extremes of range of motion for their activity like athletes, this range may be lower. Presence of pain at the extreme of motion, and presence of a mechanical bony impingement like loose body or osteophytes, which are less likely to respond to non-surgical treatment. So prerequisite for elbow contracture release is presence of a congruent joint with adequate joint space, willingness to participate in a structured extended rehab program, having a good soft tissue coverage, and in certain situations like HO, we got to make sure that the inflammation is resolved before you go ahead with the contracture release. So for elbow contracture release, the basic principles are that we are releasing or excising the contracted tissue, and we are going to be debriding the mechanical block. So there are typically 4 things in the front and back of the elbow that have to be addressed, and they include capsule, which is typically excised. We have to recreate the olecranon, the radial, and the coronoid fossa. Loose bodies and osteophytes are removed, typically from the olecranon tip of coronoid, and the medial and lateral gutters. And then finally, tenolysis of the triceps at the back and brachialis in the front. If there is HO or extra-articular soft tissue restraints, they have to be excised, and depending upon the situation, the ulnar nerve will have to be released or transposed. So if we have to improve elbow flexion, we want to release the tight structures posteriorly, and we want to decompress the mechanical block anteriorly. So this would entail removing the posterior capsule, doing a triceps tenolysis posteriorly, and anteriorly removing coronoid osteophyte, recreating the radial and coronoid fossa. And if there is severe limitation of flexion, you can release the posteromedial capsule with the UCL, posteromedial part of the UCL. If elbow extension is an issue, then we want to decompress the mechanical block posteriorly and release the tight structures anteriorly, and this would entail removing the anterior capsule and doing a brachialis stenolysis, removing the olecranon osteophytes, recreating the olecranon fossa, and removing loose bodies from the posterior fossa. So the elbow release can be done either open or arthroscopic or combined. Arthroscopic approach depends more on surgeon's comfort. Definitely it has less morbidity compared to open and is particularly suited for mild to moderate deformities, although experienced arthroscopists can do even severe deformities. You can be tested on relative contraindications, which most common one to be tested is if a patient has a prior history of ulnar nerve transposition, then he's at a higher risk for injury, and preferably an open approach should be utilized, even though there is a described surgical technique to do an elbow arthroscopy in patients who have had a prior ulnar nerve transposition. Open approach is more common. More surgeons are familiar and comfortable doing this approach. It's particularly suited if a patient has had a prior elbow surgery, especially in an ulnar nerve transposition. If patient has an internal hardware present and needs to be removed, and also in cases where there's severe deformity with a lot of osteophytes and ankylosis. The open elbow contracture release can be done from a lateral approach, a medial approach, a posterior approach, or an anterior approach. The surgical approach, the selection of surgical approach is determined by surgeon's preference and other factors like if there's a need for ulnar nerve decompression, if there is any HO and that has to be removed, if there's a presence of hardware and prior surgical incisions that have to be taken into account, and if the surgeon thinks that there will be a need for future elbow replacement. Irrespective of the approach for this surgery, the most important thing is to protect the vulnerable neurovascular structures, especially the nerves, which constitute one of the most important and common complication following this procedure. So the first approach is the open lateral approach, which probably is the most common approach utilized. It is also called as a lateral column or an LUCL sparing approach. It is really good for mild to moderate contractures. It is simple, safe, and causes less muscle morbidity. And it exploits two intervals, which I'm going to show in the next slide. The disadvantage of this approach is that you require an additional incision if you have to do an ulnar nerve decompression or you want to release the posteromedial capsule in order to achieve more flexion. So in lateral column approach, it is a lateral-based approach. The incision is more like a Coker kind of an incision. And the deeper dissection is in form of an inverted Y. And in between the two limbs of the Y is the LUCL, and that's why it's known as a LUCL sparing approach. So the proximal part of the Y, if you need to access the posterior compartment, you elevate the triceps off the supracondylar ridge and the posterior part of the humerus, and distally this incision extends between the anconeus and the ECU. As you can see here, distally, the radiocapitellar joint has been exposed, and the posterior part of the limb here is along the supracondylar ridge. In order to expose the anterior compartment, again, the proximal part of the incision involves elevating brachioradialis and any brachialis off the anterior part of the humerus. Distally, this incision extends between the ECRL and ECRB. As shown here, you can see this is the front distal part of the incision, the proximal part of the inverted Y, and distally for the posterior part of the incision, it's going to be between the ECU and anconeus. And you can see here the front part of the elbow exposed. You have a very good view of the capsule, which is being excised here, and then you can do rest of the bony work, which includes deepening the radial and the coronoid fossa, removing the osteophytes, and taking out the tip of the coronoid. Once you are done, this is what the deep part of the closure will look like. It's a very small incision, somewhere around 5 centimeter, and you can access pretty much everything in the front and back of the joint except for the posteromedial capsule and ulnar nerve. The open medial approach, the advantage of this approach is ability to decompress and transpose ulnar nerve. It allows correction of severe flexion deformity because it allows you access to the posteromedial part of the UCL. The other good thing is that the scar is not visible. The disadvantages are that it's a longer scar, which is more sensitive because the MABC invariably will get either irritated or stretched. And you cannot expose and address lateral-sided pathology, which is more common. As you can see here, obviously a bigger incision. You have to protect the MABCs, which are close to the fascia than in the fat. Once you get down to this stage, you can either proceed posteriorly or anteriorly. Typically, people will locate, surgeons will locate the medial intermuscular septum, find the ulnar nerve, transpose it out of the way. For posterior approach, you lift off the triceps from the supracondylar ridge and the septum and the posterior part of the humerus and gain access to the joint where you can do all the bony work and excise the capsule. For anterior exposure, which is what most of the people are not comfortable with, involves separating the anterior 3/4 or 4/5 of the flexor pronator mass distally, proximally elevating brachialis of the septum and anterior part of the humerus. This protects the anterior band of the UCL and will also protect the median nerve and brachial artery. So here you have a very nice exposure of the joint. You can do the bony work and release the capsule, and after closure you can transpose the nerve anteriorly. So the posteromedial capsule release is done in the floor of the cubital fossa once you have transposed the nerve anteriorly, and you can safely do it by running the knife along the margin of the olecranon but not going past what we call it as the bare area of the olecranon. So open posterior approach, it's a utilitarian approach, allows you to access both the medial and lateral side. It is compatible with future total elbow arthroplasty. The disadvantages are that it's a bigger scar, and because a lot of subcutaneous dissection or tissue elevation, flap elevation is done, there's a higher risk for postoperative seroma and wound complications. There's some other approaches that you may be tested, I'm not sure, but it's worth knowing. One is called the OFER approach, which is the olecranon osteotomy facilitated elbow release. And then the OK procedure, which is relatively popular among trauma surgeons, as you can access from a typical posterior incision, remove the implant, do the ulnar nerve release, and you could do contracture release for both front and back through a single incision. And then the anterior approach, which is pretty popular with the release of pediatric contractures, or if an HO excision has to be done. So arthroscopic elbow release gaining a lot more popularity. There's certain principles that have to be followed. The key thing is time is of essence. You have to stay under the learning curve, start with simple cases. With respect to pump pressure, it should be less than 30, or one should use gravity alone. One should use soft tissue retractors, especially in tight compartments, for better visualization. Avoid suction, a direct suction on either shaver or burr, and let it be gravity dependent, especially when you're working near the nerves. And you should know how to switch to an open release if there is swelling. So surgical steps have been elegantly outlined by Dr. Sean O'Driscoll, but the typical steps are to get in and establish a view, create a working space, do the bony work first and then the capsulectomy, and finally release the loose body, finally remove the loose bodies. The loose bodies sometimes can be big enough and you need to increase the size of the incision. You don't want to do it at the start of the case, otherwise it will be very difficult to maintain pressure within the joint. Portals, I think we should definitely go through this because I feel that what you guys are going to be tested on this will definitely include the complications, and the most common complication being the nerve part is what they're going to be testing you on. So for elbow contracture release, the proximal on the medial side, for anterior portals, anteromedial portal is most commonly utilized. The anteromedial portal is typically a distal portal, and I know this lingo sometimes becomes really confusing, but I think anteromedial portal is typically a distal portal. Proximal anteromedial portal is what we normally use, which is 2 centimeter proximal, and anterior or 1 centimeter proximal, and is relatively safe. The only thing it can get close to will be the MABC. On the lateral side, the anterolateral portal, which is right across the radiocapitellar joint, and the proximal anterolateral portal are two most commonly used portals. On the lateral side, again, within the 2 centimeter territory, the more distal you are, the more likely you are to injure the radial nerve or the PIN. And the more posterior you tend to drift, you are more likely to injure the posterior antebrachial cutaneous nerve. Posterior portals, typically, most commonly two portals are used, the direct posterior portal and the posterolateral portal. Again, remember there's no such thing as posteromedial portal in elbow arthroscopy. You can do it, but it's like frowned upon. And the nerves that are at high risk are the ulnar nerve, and then for the posterolateral portal is the posterior antebrachial cutaneous nerve, as shown here. This is a typical slide for how the elbow arthroscopy pictures look during debridement. Again, enter into the joint, create a room for work, do the bony work first, and then the capsular release, and finally the osteophytes. It's your choice. You want to go to the anterior compartment first versus going to the posterior compartment first, depending upon the pathology. Ulnar nerve release. So indications for ulnar nerve release are if patient has ulnar neuritis symptoms, or if patients have signs of ulnar compression neuropathy. Routinely it is advocated that if your preoperative elbow flexion is less than 90 to 100 degrees, you should prophylactically release the ulnar nerve. Post-operatively, sometimes you have to do an emergent ulnar nerve release, especially if you have a delayed onset ulnar neuropathy, the rapidly progressive variant, which I'm going to talk about in last few slides. And in this case, you have to do in first few weeks after an arthroscopic capsular release. The options are doing a mini open release, which people typically do when they're doing a prophylactic release, and a standard release with or without transposition, which people do when there are typical symptoms either of neuritis or of neuropathy. Post-operative treatment, typically an outpatient procedure, but sometimes patients are admitted, especially if surgeons prefer to do CPM within the hospital. A regional block is preferred. Physical therapy for me starts on day one and continues on an average anywhere between 3 to 6 months. The use of CPM is controversial, and I think you can be tested on it. No randomized controlled trials that show superiority of CPM in achieving an improved flexion extension arc. HO prophylaxis, there are no definite guidelines. I typically use indomethacin, 25 TID or 75 sustained release for 21 days. Definitely, if somebody has a history of HO or I am treating HO during this elbow capsular release, I would go for a low dose external beam radiation within 72 hours after surgery. Drain, again, optional depending upon the extent of surgery. In initial part of my practice, I would put drain for 23 hours, but now I do not use drain. Outcomes. Elbow contracture release is highly predictable for pain relief. It is interesting that even though the surgery is called surgery for elbow stiffness, but the principal reason to have surgery is actually elbow pain. And as I said, if patient has pain at the extremes of range of motion, this operation would pretty much take away all the pain. But if you have pain throughout arc of motion, which is more of a synovitic inflammatory pathology, the pain relief is less predictable. There is relief from mechanical symptoms by removing the loose bodies, and an average gain of range of motion after this procedure is between 40 to 50 degrees of flexion extension arc. These results persist for at least a decade, and it has been shown in studies, but younger patients tend to lose range of motion over time, and the exact reason for this is not known. And when I say younger patients, it's actually more of pediatric and adolescent and 20 years old. So complications, something which you definitely can get tested on. Nerve injuries. The incidence of nerve injury after arthroscopic ranges anywhere between 0 to 14%. Definitely arthroscopic incidence is much more than open. In both arthroscopic or open procedures, ulnar nerve is the most commonly injured nerve. Majority of injuries are neuropraxias, and they recover over a period of time. The risk factors are if a patient has risk factors for nerve injury after arthroscopic procedure, if the arthroscopic procedure is done in the setting of RA or severe elbow contracture. Persistent drainage from arthroscopic portals is one of the more common complications that has been reported in large series by Sean O'Driscoll and others. Wound hematoma or seroma, especially when you do a posterior approach with big flaps on either side to go both on medial and lateral side. Intraop fractures are typically with manipulation under anesthesia. HO, the incidence is not very high, but it has been reported. Again, instability, if there is, during the medial approach, if inadvertently you release the anterior band of UCL, or when you're doing a lateral approach and you're not respecting the tissue planes and you release the LUCL, they both will result in instability and stiffness, which is the worst thing to have. And then recurrence of mechanical symptoms if you miss loose bodies. And that is why it's really important that when you're doing either arthroscopic or open release, that preoperative CT scan will give you a good idea where the loose bodies are, and you can make sure that they're not hiding in the gutters. So delayed onset ulnar neuritis, it is a complication that is specific to arthroscopic capsular release. And the variant that you guys need to know is the rapidly progressive DOUN. So this is a sensory motor neuropathy that develops within first week after arthroscopic release. It presents as severe pain in cubital tunnel syndrome and sudden loss of range of motion. It's important to recognize it because you need to take the patient to the operating room and do an ulnar nerve release. And if it's done within first 2 to 3 weeks of presentation, the results are good. When done later on, the recovery of range of motion and ulnar nerve symptoms is not complete. The other two variants are less serious, the non-progressive and slowly, which present mainly as sensory symptoms and gradually advancing neuropathy. Risk factors for developing DOUN: if you have a preoperative HO or preoperative neurologic symptoms, you are more likely to develop this. Presence of severe contracture, especially severe loss of extension preoperatively, predisposes you to DOUN. So with these risk factors, it is advocated that you should do a prophylactic cubital tunnel release. And that's it for me. Thank you very much. And if you guys have any questions, you can email me. Good luck with everything.